Welcome back, everybody. We've had a jam-packed several days of Health Impact, and we couldn't finish it off in a better way than having Jefferson Health CEO, Dr. Stephen Klasko, talk about a book that he's recently co-authored called Unhealthcare, a Manifesto for Health Assurance. It's a fascinating book, and I'm looking forward to this conversation with Stephen here. Stephen, tell us a little bit about yourself and the time that you've spent at Jefferson.
So I'm probably an unconventional CEO. I started my career as a DJ. Somebody reminded me that was back when doctors made more than DJs. With my current hairdo, I could be a 70s pit bull, but that wasn't in the cards. Became an obstetrician and really spent most of my research career looking at what makes doctors different than other people in how we handle change. And that was an interesting area of research until all the change happened. And then all of a sudden, that became very popular. And simply put, the way we select and educate docs, we create autonomous, competitive, hierarchical, and in some respects, non-creative folks at a time where healthcare needs creative, flexible, passionate, and nimble folks. So I think that if there's one thing I can put out there is whatever you are in whatever kind of healthcare entity you're in, the ability to be creative, nimble, flexible is going to really be the new world order and frankly the new currency in this post-COVID world.
Yeah, that's so true. I've had the privilege of speaking to a number of your physicians in I think there was a digital grand rounds that we did a few years ago in a few different sessions talking about interoperability and digital healthcare, et cetera. And what I found fascinating is so many of the doctors that were asking questions were more about, well, these are all great ideas, but how would we actually make it work in healthcare? Isn't healthcare so much more different? You know, we have different ways of getting paid, et cetera. And that's really what I found most fascinating about the book itself is targeting and talking about the idea that healthcare really isn't as different as we think it is from other industries. And in the areas that it is different, we have made it different from within, then more so with patients in the outside world thinking that it's different.
Yeah,
about this idea of thinking differently, I know you started, another thing you did differently than a lot of other doctors is you spent time at Apple, and Apple being a user experience company. Tell us a little bit about your time at Apple. I know you spent some time with Steve Jobs before he passed. What did you learn from him and Apple that you're applying at Jefferson?
Yeah, so look, I think really learned a lot, and this was pre-iPhone time, and I was part of a group looking at iTunes U Health, but he talked pre-iPhone, and again, this was Apple stock was 15. That was about 87 splits ago. If I had kept some of my stock, I might not be talking to you today, but. Look, I think at the end of the day, he talked about the old math and the new math. And to him, the old math was computers and operating systems. And the new math was this thing called digital lifestyle, which he felt would be the norm 10 years from now. What was amazing about that, not everybody bought into that because their entire revenue was based on computers and operating systems. So, when I got to Jefferson and we moved from a 2-hospital, 1-campus university to a 14-hospital, 2-campus university and merged with a design and fashion university. And I started talking about the old math and new math. The old math for us was clinical, 14 hospitals, and academic in-person tuition. And the new math is innovation, strategic partnerships, and venture philanthropy. And same kind of thing. Wait, all our math is over here, but that's not where the math is going to be. So, telehealth is just such a great example. We invested about $35 million in telehealth, interestingly, with Teladoc, which is part of the partnership with Livongo. We were one of the first partners with Livongo also. But literally, we invested that, and we did 100,000 telehealth visits between 2015 and 2020. And then we did 100,000 telehealth visits in 3 months during the pandemic. The supply didn't change, just demand changed. And I think the thing that really attracted him and I to each other is we said, stop talking about telehealth. We call it healthcare at any address. And I use banking as an example. Nobody got up in the morning and said, I think I'm going to telebank this morning. It's just that 90% of banking went from being in the bank to being at home. And 30 years ago, if we had a pandemic, we would have been talking about people lining up on Fridays to deposit. what Heyman and I believe, and what is really the key of that book, is that we're going to move to a point where 70% of healthcare happens at home with virtual assistants, with continuous data. And those of you that are out there that are CIOs, CXOs, et cetera, are going to be literally chief transformation officers in a very different model. The only question is whether you recognize that or not. And I'll just leave you with this as far as the Apple thing. You have to decide, are you going to be Gateway arguing that you're competing with Dell, or the better example would be Sears saying, as long as I can beat pennies, I don't have to worry about these stupid Amazons and Walmarts. Or are you going to say, oh my God, this is the world that's changing, and I'm going to have to make some short-term pain to be ready for that change?
Yeah, that's a great point. And when you think about, so you've been teaching a lot about not treating the hospital across the street as your primary competitor from a strategic perspective. It's much broader than that. Talk a little bit about that. Who are the actual competitors for hospitals if it's not just across the street? And should the hospital across the street be think about co-opetition in the digital space and in the computer science space. We do this all the time. Microsoft is huge enemies of Google and Oracle, but at the same time, they work together to collaborate on open source software and other things. So co-opetition in our industry, like in the healthcare and outside of healthcare, meaning in the computer industry, is very common. Co-opetition seems to be something that healthcare should be promoting because it's about the benefit of the patient, but it looks like it's not. Why is co-opetition so hard in healthcare? And why is it that only hospitals see each other as competitors rather than the wider world?
Well, I think it's partly because we've been brainwashed into thinking that the hospital across the street is the competitor. And I can tell you, because I have 1 foot in Silicon Valley and one foot in the traditional healthcare ecosystem, that, those folks laugh at us, because they say, you think at Jefferson, you think Penn is the problem? We're about to come in and eat your lunch, whether we're think about United and Optum. Optum was sort of a small technology provider-driven thing. Now that's no longer the tail wagging the dog; it's the tail that ate the dog. Mm-hmm. Because United is smart enough to recognize that being the middleman, it was a great gig when you can make 17 cents on the dollar to make sure the people that pay for the care, get the care, and provide the care can't talk to each other. But that gig's up, and I think places like United have gotten it. Chapter 4 of our book is the end of health insurance as we know it. They will become different competitors because they're not just going to be middlemen anymore. And we need to look at that differently too. How do we use technology to be direct to employers? So I guess one of the things that I think is really important, getting back to diversifying your portfolio, where you're making money today, if you're a healthcare provider, could become a loss leader. And I think one of the things that we've tried to get away from is vendor-vendee relationships. So you get back to, your competitor. If you and your competitor are talking to a startup and you can look at a way of earning equity in that kind of thing, get back to Livongo. In 6 years, they went from being a philosophy to an $18.4 billion sale. We have to get away from that concept of we're helping companies start and we're going to be a vendor. I'll give you my first lesson in this. I won't give the name of the company, but as a CEO at University of South Florida, helped the company develop. We were their first customer. Forgot about it about a year and a half later. I get a call. Steve, I really want to take you out to dinner. We just had an IPO at $1.5 billion. I could not have done it without you, and I could not have done it without your organization. And I said, hey, that better be a hell of a dinner because you just had a $1.5 billion IPO. So, our relationship now, in fact, one of the really cool things, and I would suggest this as you get together with other healthcare systems, we'll be announcing that General Catalyst, which is Heyman's company, and us will actually be sort of creating a new co in Philadelphia. So folks from General Catalyst will be on my cabinet looking at what kind of digital transformations can solve some of my problems. Because if I have that problem, there are probably 870 other hospitals that have that problem, and that can become a product. And then we'll co-invest in those kind of things. We have a company that we've worked together on called Commure, which is literally a fire layer on top of Epic or Cerner or Allscripts or whatever. It can almost create an app store. But those apps are some of them are coming out of what does Jefferson need in its 14 hospitals? So I think this whole issue of strategic partnerships with outsiders and getting away from the outsider versus insider thing is a really important lesson for the folks that have been listening to this conference for the last couple of days.
No, I think that's so true. When you think about this idea, though, as you move from, let's say you're a chief information officer, you're a chief technology officer, chief financial officer, you're supposed to fit into the organization that you're in. And if your organization isn't thinking like this, what do you do? I can think of three things. One, just accept it and
become the Jefferson if you're good.
And move on. Or don't accept it. Leave the facility, and if enough people leave because the proper strategy isn't being taken, the people will notice that, the board will notice it, et cetera. Or the third option, which is start to give your board, your chief executives and officers and CXOs another way of working. So if that was another way of working, based on what you've done at Jefferson, what's easily replicable in other hospitals and what maybe isn't, because you have a different position within Philadelphia than a lot of other organizations do within their organization, within their own geographic areas. What could people who really wanted to make a change do within their organizations pretty quickly?
Well, look, I think you have an obligation, and your CEO has an obligation to look at what's going to be obvious 10 years from now and what you need to do today. And I think, it really depends. In my case, it was pretty simple. I took over a 195-year-old organization that had separate leaders of the university and the hospital, and they brought in a single campus leader. We were a very conservative organization. I thought it was a joke when the search firm first called me. I told them to Google me and make sure that they were really interested. But when I first met with the faculty, it was sort of funny. They said, everything was in the traditional 90s and 2000s. Tell me about Jefferson that will get me excited. Well, we're number 2 to Penn in NIH funding, and we're number 2 to Penn in U.S. News and World Report, but we're ahead of, the others. I said, that's the opposite of exciting. And we started to talk about what's going to be obvious 10 years from now. Let's be very different. Let's be the entrepreneurial academic model. We came up with a model of what if a 195-year-old academic medical center thought like a startup company. And, then as with anything else, things have to happen. We got a $110 million gift from Sidney Kimball because he believed in that kind of thing and he had that creativity. But I think, look, every place starts from a different ground zero. I think what I would try to do is, not that I'm trying to sell the book, but I think, if you read that book, you realize that there are people like Haymont and the venture capitalists that will either work with you or eat your lunch. It's hard not to read that book and read the part about how Silicon Valley is approaching healthcare and not think that there's either an opportunity or a threat.
Right.
Then once you do that, then I think you can start to literally talk to your board and your CEO about how you can do both. And the way I do this when I talk to boards, especially from conservative organizations that are just dealing with this, I say, look, I want to be Target and Walmart. And this is what I mean by that. When Amazon came in, there were some places, oh my God, we have to be all E. And they didn't make it because they didn't have what Amazon had. There were places like Sears and Penny's that said, what a stupid fad. That's never going to happen. What Target and Walmart said is, hey, we're really good at what we do, but this is going to be a new vehicle for retail, so we have to do both. And I think that's where I think you can get your CEO or your board less scared. You're not turning into this wild Silicon Valley firm, but clearly there is going to be a digital transformation of healthcare. There is going to be more at home. I mean, I'm an obstetrician, and I'm on the board of a company that's looking at monitoring for people that need non-stress tests and those kind of things at home. Now think about this, 28-year-old pregnant patient does not view herself as a patient. She views herself as a person that happens to be pregnant. Now think post-pandemic. The chances that she's going to need a non-stress test of monitoring every three times a week. So let me get this straight, Steve. You want me to come into Jefferson, spend $35 to park 3 times a week, go to a place where there's a lot of sick people, maybe even COVID people, go up in an elevator, have somebody slap monitor on me that 10 other people have used. I know you've disinfected it. stare at the ceiling for 2 hours so some nurse can come in and tell me my baby's okay. When I now have an alternative, I could be at home watching Little Fires Everywhere, drinking lemonade, and have a nurse come on telehealth and tell me my baby's okay. I don't think so. So the key is recognizing that a certain part of your consumers is going to have that I'm mad as hell and I'm not going to take it anymore about a sick care, hospital-centric, insurance-centric, corporate-centric mentality, and not give up everything else you're doing. Because you know what? If a patient has pancreatic cancer, God forbid, they don't really care about your website. They don't care. They want to go to the best surgeon. They don't care how big the TV is or any of that stuff. So I think you can convince your CEO that it's a both and instead of an either or.
No, I think that's exactly right. And when you think about, over the last 20 years, there are lots of Silicon Valley carcasses on the road to the successful healthcare startup. You can everything from Google Health in many days ago to Microsoft's Zixi, et cetera. Now, what's different about those times is that those were companies that were trying to take their strength in digital and bring it to healthcare, but focusing still on the digital part, not the healthcare part. What I see that you're teaching us today going forward is those same companies, and maybe different companies from Silicon Valley, have realized that healthcare is the business to be in, not healthcare IT, not healthcare computing, not digital healthcare, but healthcare itself. Health insurance has recognized, we're a financial instrument today, but there's more money in being the financial instrument which does the actual care. Is that what you're teaching us? Is that these other companies that are coming in are not looking at tangential IT or financial, et cetera. They're going to get into the care side, and it will obviate many hospitals and facilities if they're not prepared. Is that the warning you're giving? Yeah,
and I think that, again, for those who read the book, it's about responsible innovation. And I think, I think what differentiates Heyman, so the book's premise starts out, what if a Silicon Valley entrepreneur and a CEO of a 195-year-old academic medical center walk into a bar, get married, and have babies? Because it's been such different worlds. And in some respects, Heyman and I met in a really weird way because we did meet at in a cocktail type setting, and he said, "I'm curious about you." He had just written his book called Unscaled. He said, "People tell me I have to meet you, but you seem like the opposite of unscaling. You just went from 2 hospitals to 14 hospitals, but everything you talk about is healthcare with no address," which is exactly what I'm looking at. So when we started to get together, what was really impressive about him, and it's in the book, he's the opposite of move fast and break things. And to your point, I think that's why some of the others, the Googles, the Amazon, you look at Haven, it's Amazon, JP Morgan, and Berkshire. And when that first came out, everybody was scared of them. And I made a comment at a national conference that they're like the Loch Ness Monster. I'll be scared of them when I see them, but I'm not sure I'll see them in my lifetime. And part of it is because what we have going for us, what everybody listening to today at the end of the conference has going for us, people trust you. They trust their doctor, they trust their nurse, they trust their health system. If you can then add the technology, they're going to trust you. There's just no way that Google or Facebook or those places can rebound and say, I'm going to get all your genomic data and you can trust me. They frankly have lost that ability. So I think we have a chance to really take some of that digital, the digital piece away from them by partnering with them, but doing it in a responsible way. We're actually looking at a Center for Responsible Innovation. And you'll appreciate this. Imagine when the Industrial Revolution happened. If we had known the internal combustion engine was going to cause climate change, we might have made some changes. When the social media revolution happened, if we had known that that Mark Zuckerberg was not just this cute guy in a hoodie so that I could see my grandkids on Facebook, but it could affect elections and spew hate, we might have put some guardrails. So in the World Economic Forum, we talk a lot about the 4th industrial revolution of drones, AI, robotics, 3D printing, et cetera. And how do we bring ethics into that from the very beginning? How do we make sure that we're not just making the wealthy healthier? How do we make sure that when I ask you for my genomics data, that you're going to use it responsibly? They'll trust Jefferson to do it. They won't trust Google to do it. Now, if I partner with Google and put in the right guardrails, but I think that's really where Haymont came in. And Livongo started out that way. Is look, we want to listen to diabetics that don't want to wake up in the morning and view themselves as patients. They want to view themselves as people that want to be able to thrive without diabetes getting in the way. And I think that's where we can really bring this best of both worlds mentality of partnering with some of the startups. I think the larger companies, it's just harder for them to do that. It's harder for Apple, Google, Amazon, Facebook, et cetera, to not think that they can't solve it on their own. But those startups and the VCs like General Catalyst and others really are ready to partner with folks like us.
Yeah, I think for leaders today, the big question basically boils down to, can I do what the digital health specialists and the digital-centric Silicon Valley style do faster than they can become me? So can I become them faster than they can become me? That's an interesting question. But really what you need to think about strategically is, what are the strengths that we have that they will never want to get into? And then say, for the what's left, right? So let's say that 80%, none of those guys want to open hospitals. We know that. None of those guys are going to go start buying hospitals. We're probably pretty sure about that. Yeah. What we're not sure about, though, is what about all the care that happens outside of the healthcare system, outside of the physical healthcare facility? So if we've made an argument that 80% of what a hospital does today does not change because it's a facility and you have to do care inside these facilities. But let's say it's 20%, 30%, 40%, whatever number you say here. Now you have to say, can we become them faster than they can become us in this area? And I think that's the piece that people aren't thinking about very astutely, which is why they get caught off guard.
Yeah.
So if you looked at what hospitals are strong in that you don't think people will be jumping into versus where they might be mediocre, but others will jump into, what could people focus on and take your advice here from the book to concentrate on and get some benefit pretty quickly?
Yeah, so I think the number one thing we have going for us is trust. And I would not underestimate that. And I think that, as the consumer revolution starts and we can leverage that trust and not be afraid to partner with folks to get care closer to home, then they won't look at it as an either or. Look, EMRs are a perfect example. I was a practicing obstetrician and people went and said, look, nobody can read your handwriting. We need electronic medical records. And our attitude was always, hey, if a nurse can't read my handwriting, we need a new nurse. So the Epics of the world, the Allscripts of the world, the Cerners of the world filled in this problem because we weren't interested. Well, meanwhile, they became billion-dollar companies. Now we're dissatisfied with the EMRs. By the way, the same thing, other than a few places like Jefferson, happened with telehealth. Well, when people say, hey, we think healthcare is going to be remote, we need telehealth, the teledocs, the American Wells, the MD Lives created outside of us because we weren't interested, or most of us weren't interested. So the question is, as these multi-billion-dollar companies get started, do you want to partner with them or not? And under what rules are you willing to partner them? I don't want to go to HIMSS anymore and have 872 25-year-olds tell me how they're going to transform healthcare. Because that's not how it's going to happen. It's going to happen from places like us. Now, I think one of the real important lessons for folks out there is this. There's a great quote from Upton Sinclair. It's hard to get somebody to do something when their salary depends upon them not doing it.
Right.
So and I'll give you a real live example. When we first got involved in telehealth in 2013, we had predicted that we could move 50% of our unscheduled care, emergency room care, out of the emergency room through telehealth, urgent care, and internet appointments the next day. The problem was we couldn't get an insurer to understand that. We would make $1,500 a patient if somebody came into our ER whether they needed to or not, and about $100 through the other means. So we took our employees, now we're a large system, 35,000 employees, partnered with an insurer, and it's a new rule. $500 deductible employees, since we're their insurer, if you just show up to our ER, zero deductible if you go through Jeff Connect and up ER. We were able to move about 50% of our patients out of our ER, save about $10 million, have unlimited patient satisfaction, And then we could prove to the insurers and employers why this was a good thing to do. So some of this is doing pilots. As we partner with folks, a lot of times I'll have my main academic hospital say, oh, we don't need them because we're an academic medical center. So I'll take, our New Jersey entities or our suburban entities, and they're like that commercial Mikey, oh, I'll try anything because they want to, and we'll prove that it works. So I think, that's what, and by the way, that's where you can start to maybe even partner with competitive hospitals, around innovation. If you have a competitor hospital, okay, that's fine. Somebody's going to choose either you or them for their neurosurgery piece, but you working together and say, I might have 1 million patients and they might have 1 million patients, you're going to get a better deal with a vendor or a strategic partnership if you're saying, in our area, we have 2 million patients. And that's not competitive. And you can create these sort of LLCs or NUCOs between the two that don't get into antitrust issues. And that's some of the things that we're starting to look at with some of our quote competitors and partners.
No, I love it. I think that's very, very creative. And ultimately, what we see in the healthcare sector is sometimes we use a lot of excuses about reimbursement, regulatory burdens, and sometimes they're not really, they're real burdens, right? I'm not saying that they're not burdens, but sometimes we use it as an excuse to say, well, nothing is then possible. What we have now seen, and I would love to and we're going to open up for questions to the rest of our audience here. They might ask you questions for several hours, who knows? So what, as you were looking at what you've learned in the last 6 months post-COVID, if you were to rewrite the book only after what you've learned in the last 6 months of COVID, would anything change in the book? And if so, what would you say differently? Or does it just double down on everything that you said in the book based on what you've learned post-COVID?
Yeah, you see, I don't believe that COVID changed anything. I think COVID just accelerated what we already knew. And look, the number one thing I changed, I own an insurance company. American hospitals lost about $500 billion. Most insurance companies doubled their net operating income. Look, I think, one of the health policy things that I think is important because, it's an election, we're a month or so away from the election. Is we've done a really lousy job in health policy. I don't want to get into, who you should vote for, but over the last 12 years, every argument has been, how do we pay for fragmented, expensive, inequitable, and occasionally unsafe healthcare delivery system, as opposed to how we transform the healthcare delivery system, because transforming the healthcare delivery system will get some people angry. So I guess what I'd say is, there's a great quote that I like to use. Jason Kidd, in the NBA, went to the Dallas Mavericks. They were 24-52. He said, we're going to turn this team around 360 degrees. We've done a lot of turning things around 360 degrees in healthcare. And I think it's partly because we've assumed that we can just go on like we are. And the insurers have a middleman philosophy. We have we can be inefficient and just charge more. I think that's the part that the pandemic has proven is over. And we're going to need different kind of partnerships to provide better care at a lower cost with greater access. And I think that we will join the consumer revolution. That's the other thing that I think will come out of this. And so instead of thinking of that iron triangle of access, quality, and cost, I like to think about it as a patient diamond of that's sort of the health assurance piece of, I want to be able to thrive without health getting in the way. I want to be able to have human connections when I need to. I want to know exactly what it's going to cost me. And I want you to be transparent. I want you to be like, I can access every other place. So I know Jefferson will be successful if 5 years from now you come into Philadelphia and say, where's Jefferson? And nobody can define that. Jefferson on my TV, or Jefferson in partnership with Temple, or Jefferson on my iPhone, or 12 micro hospitals. Oh, the place where really, really, really sick people go to get transplants. I think that's still a 10th of Walnut. And that's more like Amazon. Nobody says, where is Amazon, or where is Netflix? It's in my mailbox, or it's on my TV, or it's and I think I'll know we're successful. And I think this is true for anybody, no matter how big you are. You want 95% of people in your service area, everybody listening to this, are people, not patients. So if you're Pleasantville Hospital and you can figure out how to get people to download the Pleasantville Hospital app because it's helping them to thrive without health getting in the way, and maybe part of that is things like Livongo or whatever, when they get sick, they will just assume they're going to go to you because they've got the app, right? The old way of, I'm going to have the biggest billboard and I'm going to go up and down the highway because I now think I might have cancer. I'm going to see who has the coolest billboard. That's ridiculous in 2020 and beyond. The key is, while I was healthy, Jefferson helped me stay healthy. Now I think I might have a problem. If it's easy on my Apple Watch or my iPhone to make an appointment to see if I have a problem, first at my house with maybe somebody telehealthing me, and if I need to come in, you're going to win. And you're going to win in a fairly short time frame.
No, I love it. And in fact, that's a great advice and the perfect way to open up to the audience. So let me challenge the audience now and say, let's play Stump Stephen. See if you've got some thoughts on what you've been trying to do at your organization. And assuming you haven't read the book yet, but you should definitely grab the book and read that as well. But even if you haven't read the book, pose some real challenges, like what are you seeing in your organization that you wish would change, that even after the massive impact that COVID has had, the $500 billion in revenue, et cetera, that people still within your organization aren't willing to adapt or change, or has all that gone away? And most of us within our organizations are seeing change occurring more rapidly than before. So with that, I'd like to thank everybody for being part of Health Impact, of course, but also open it up for questions so that Stephen can spend all the time with you one-on-one. Thanks for a great closing keynote for us. As you saw in the chat, lots of questions, and you were pretty nimble being able to speak and type at the same time. That was magical.
I think there's a good question out there from John Warner. Is the current healthcare system more prone to cognitive biases than most? Groupthink, anchoring, experience confirmation, competitor neglect, et cetera. So how do we change this? So I think the answer is yes, and I think probably John knew that. So it's a bit of a rhetorical question. And I think it's two reasons. When you think about what causes change, change either causes from within a sector, where all of a sudden you get sort of very different kind of leaders. It causes from the consumers saying, boy, I don't like the way I'm getting treated here. And the third piece is it requires an alternative. We haven't had any of that. The average person in my job running a $5 to $10 billion, academic medical center is 67. They've got their long-term retention out in 2 years. And their choice is, do I work harder than I've ever worked and change everything and upset everybody that's also 67 and been my friend, or do I just wait for the next guy to take over and let him do it? Well, you know the answer to that. Patients have allowed healthcare to escape the consumer revolution, right? I wrote an article that patients have way too much respect for the medical system. I got in big trouble for it. But what I said is, if you have an appointment at 8 o'clock and your doctor comes at 8:45, 90% of the time you're going to say, Dr. Klasko, that's okay. I'm sure you had an emergency. And what I said in this article is, that's true about 15% of the time. The other 85% of the time, the doctor was at grand rounds or she was at breakfast, but they know you'll excuse it. Well, you wouldn't excuse it in any other industry. And then the third piece is, the excuse has always been, well, we have no alternative, right? I can go to, X hospital or Y hospital. I'm going to be dealing with, arrogant folks and a lot of administrators. And so what difference does it make? Well, I think that now that you're starting to see some of those outsiders come in, and again, I gave the example in our talk about the pregnancy company that's doing remote monitoring. I mean, I think you're going to start to see in Philadelphia, people say, well, wait, my friend didn't have to go into the hospital 3 times. That seems insane. Why can't you do that? Mm-hmm. And by the way, we've already seen that, when it comes to individual patients. Back in the early 80s, I was one of the first people to do, laparoscopic surgery in gynecology. It took a lot of the older doctors a long time. But at some point, patients would go to a doctor and they'd say, well, I'm going to go and do a big incision. They'd say, well, my friend just went to Dr. Klasko and, she was out in a day. And you start to see things change. So I think that's what will happen. I think the other point to his question, though, is we have to change the people that we bring in as administrators and change the way we select and educate docs. We still select docs based on science, GPA, MedCats, and organic chemistry grades, and we're amazed doctors aren't more empathetic, communicative, and creative. Similarly, healthcare administrators, they're not the kind of folks generally that you want to hang out with. And so creativity has not been creativity, nimbleness, and flexibility have not been the ingredients for either healthcare administrators or doctors. And I would argue those are three skill sets that you need.
Yeah, and Neil mentioned it as well in one of his earlier chats that administrator education needs to look more like doctor's education, at least with that seriousness. And so, what would that look like? And what is the training that hospital administrators do go through today that could dramatically change in some reasonable way within a short period of time?
Well, look, I'll start with our doctors and nurses. We started a program where we erased all the objective criteria. We started to choose physicians based on self-awareness, empathy, communication skills, and cultural competence. And we partnered, interesting, with Southwest Airlines, because Southwest Airlines used to choose pilots the way we choose doctors. Shahid, you were 97th percentile on the simulator. I was 96th. You're going to be the pilot. Then they realized that the guys that landed in the Hudson were not because they were 0.01% better technically. It was because of how they communicated. So I think we've started to I won't go into all the details, but we've started to change that. By the way, once you start to do that, you triple diversity. Because there are people in Philadelphia that pay $100,000 to get little Johnny or little Mary 5 Princeton reviews and 3 tutors to pass the MedCats, and that's without even photoshopping their head on a crew member. And there's another kid with a battered Barron's book. That's not a fair piece. When it comes to healthcare administrators, I think what we've tried to do is take a very different approach. I don't look for people with MHAs. I always tell every one of my mentees when they say, well, should I take a healthcare MBA? I say, no, you're going to be learning from all the people that screwed up the system. I got my MBA at Wharton. I make sure I did not take one healthcare course, but it was helpful to learn how the American car industry got out of its doldrums, what Apple did to get out of its doldrums. And so I think that's what we have to do. We have to get people from other industries. And you're starting to see some major health systems bring people in from Amazon. I have a group from Ritz that's looking at how we create move our hospitals from hospitals to community centers of well-being. So I think you're starting to see some of that.
Yeah, it makes sense. And John has a pretty good question. John Donnelly said, you mentioned a way to use pilots to help convince the payer to help fund your transition. Any suggestions on how we can improve the funding to move to your new healthcare delivery model at scale?
Yeah, so I think I get accused of being anti-insurer, and I'm really not. I'm anti 17 cents on the dollar to be a middleman. And I think more and more insurers, look, just like we need to have hospitals that don't get it, that are leapfrog Ds that are expensive, et cetera, they have to go under. That's the market. We have to have insurers that don't get it go under. That would be the best thing that could happen. I think what I'd say to the person that asked that question, I think more and more insurers are looking for providers that are willing to do some of these pilots around value and social determinants, et cetera. We have this huge disconnect. They assume that we just want to charge a lot, and we have a history of going behind the door and saying, we're not going to go be on your insurance plan if you don't give me 7% more. We accuse them of being middlemen, and we don't talk to each other. But I think that is one of the positive effects of COVID. I think it's really gotten some very different discussions with insurers.
Yeah, I think that's exactly right. And do you have a hard stop, or can you go over a couple of minutes? There's
we go a few more minutes. Yeah.
Great. So John Warner, different John, asked, don't we need to play defense and offense in healthcare? So often defense wins at the expense of offensive innovation.
Yeah, I think that gets back to the Target and Walmart thing. I don't think Penn Temple and Cooper are my biggest competitors. But you know what? When it comes to somebody having a stroke, they're going to choose Penn, Temple, or Drexel. Target has to compete with Best Buy and that kind of thing, but they also decided. So I think, yeah, if you're a hospital system, the world's not going to change tomorrow, and you still make a lot of money, or a lot of your money from folks coming in, staying in the hospital for 2 days and getting surgery. You lose a lot of money with some of the other things. So I don't think it's an either or. I really don't.
Got it. Yeah. And so a couple more questions. Kat Jong said medical school and residency select for people who are great at following rules, which is the exact opposite of what you're suggesting for creativity, nimbleness, and flexibility. How could systems better support those with those traits going through not feeling stifled with creativity?
That's a great question. So I think my suggestion would be the thing we least invest in that is most important is training our current doctors, our current medical staff, our current nurses for this new reality. And at Jefferson, we started something called JOLT, Shahid. It stands for Jefferson Onboarding and Leadership Transformation. It took 40 people a year, but here's my one suggestion. We looked around the country at medical staffs, and it's almost amazing how homogenous this is. 20% of your docs will get it. They'll follow what you do. Yeah, you're awesome, Steve. 15% of your docs will never get it. And then there's the 65% in the middle. What we found is that leaders spend about 40% of our time with the docs that get it because we like them, they like us, play golf together, blah, blah, blah. We spend about 45% of our time with the docs that'll never get it because they're loud and we can cure anybody. And we spend the least amount of time with people in the middle. What we did at Jefferson is we said, look, we're going to spend less time with the docs that get it. They'll become the teachers and the mentors. We're going to ignore the folks that never get it. We call that administrative hospice. We just let them be comfortable and hopefully go away to some other land or some other system. And we concentrate most of our time and effort on the 65% in the middle. And we just did an article for the Sloan MBA thing of 6 years of that, of looking at 40 people a year going through JOLT. And they had a 325% increased sort of loyalty to the organization. I could go down all the things, but we taught them to think differently. Because in essence, the way we select and educate docs, we've joined a cult around those biases of autonomy, competition, hierarchy, and non-creativity. So you almost have to deprogram the cult before you can get docs to be ready for the future.
Yeah, I think that should work. And for those of you that have questions that Stephen maybe can't answer on live, I assume you're okay with them emailing you asking for some of these suggestions. You'll be happy to do that. Eric asks, with health systems investing in their innovation teams and VCs, they have and innovating in their own innovation teams and VC, they have many advantages in the marketplace, in real life simulations, resources. How does that change the game for traditional VCs that are not attached to hospitals? So do they still have some benefits that maybe hospital-connected VCs maybe do not?
Yeah, look, I think the key is there's always going to be opportunities to be a vendor. There's always going to be opportunities to be a partner. I mean, it's the same thing with insurers. I mean, some insurers are going to choose to partner. Some insurers will be a vendor for some folks, and I think that's true of VCs. I mean, we have a lot of startup companies that we just buy their product. And the fact that we bought their product probably helps them move along. We don't have any investment in them. They don't have any investment in us. We just announced today a company called Tendo, which will be that thing that I talked to you about, which was taking our entire digital innovation and consumer experience team, bringing it together with General Catalyst, and having those people from General Catalyst actually sit on my cabinet and actually create companies to solve our problem under the assumption that if it's a problem at Jefferson, it's probably a problem at many of the other places. So I think if there's VCs out there, it's a great time to invest in health-related companies. I think where people like Haymont and Ido Schoenberg and American Well, paved the way. You put digital and health in the same sentence, you could probably do an IPO today. And you add a little sprinkle of AI in there, man, and that's $300 million right there. So I don't think you need to necessarily partner with hospitals. I do think hospitals need to diversify their portfolio outside of just heads and beds, and I think that VCs that are willing to create consortia, or look, I'll give you an example. There's a company that we're working with, a revenue cycle company. Now there are 2,000 revenue cycle companies. So what this company did that was really smart is they said, you know what? We're going to take 5 keystone health systems. And we want you to help us develop this product. But what we're going to do for you is we're going to guarantee you a 5x return. So here's the story. If you're going to pass $2 million a year on a 3-year contract, and you will get $10 million back in revenue cycle. And if you don't, we'll guarantee it. So think about that. That's relatively inexpensive for them. They can now say we are now tied to, pick the places. I don't know exactly which ones was, but let's assume it's places like Mayo and, Jefferson and UCSF, whatever. Other places are then going, well, okay, if they're using it, that's great. And then once we successfully get that 5x, they'll be able to say, I came to Jefferson and they got 5x. Now, there are a lot of companies that said, if you buy my product, I think you'll get 5x. So you follow what I'm saying? I don't have an investment in this company, but I think they're going to do very well, and they're going to use me as an example. And it wasn't hard for me to get my team to say, yeah, I'll talk to those guys.
No, I think that's a very important point, is that many of us in the technology sector don't actually believe in what we say. That's why we don't make guarantees, right? We are famous for being the only industry, when you buy our product, we explicitly tell you what we are not guaranteeing, right? Nobody else does this. The car manufacturer doesn't say, oh yeah, drive my car, but here are the 5,000 things you will never be able to do to us. You can't sue us, you can't do this, you can't do that. Right?
And there's a question out there about, creating an educational services company. I think, look, academics is as screwed up as healthcare. I mean, and I happen to be in both because I run a two-campus university.
Lucky you.
But the concept of, pay $60,000 to get a business degree at Jefferson, I don't think that's going to last very long. And, and I think there are companies, there's a company called Guild that's looking at different ways of bringing, even before COVID, of online hybrid. Southern New Hampshire University has probably been the fastest growing university in the country by taking people that currently have jobs and getting them advanced degrees for like $10,000 instead of $60,000.
Yeah.
So I was just on a Forbes conference, and somebody was saying, post-COVID, the 2 things you don't want to be running for the next 5 years are academics and healthcare. And I was the next speaker, and I was like, well, damn, I'm doing both. So, don't be me.
So if you're able to, there's 2 more questions on the list that really are good. One is by Kim. She's asking, how are you partnering with home health organizations differently now? And then Neil has one question, which I'll close out with once you answer the home health one.
Yeah, so I think we're having some great discussions with home health folks. We've looked at some partnerships with places like Biata and that kind of thing. And I think the home health thing is a good example. It's I have some home health, but that's not my top skill set. That's what Biata does every day, and that's what Select does every day. I just picked Biata because I know David, but the issue is I don't want to just give up all my home health to them. So having different kinds of discussions, and the beautiful thing about it is when you start to have creative discussions, everything comes out. Like David Biata was talking about, like, gosh, I'm going to have to teach all my people at home health a lot about AI. Well, I have a certificate program in AI in our Institute for Emerging Health Professions. He has like 100,000 employees or something. So, the fact that I might be giving up a little bit of EBITDA by handing over, some of our home health to him can easily be overcome by that kind of thing. So I've been impressed that when you start to talk to people in a creative way and you're willing to look in the mirror and not come off as arrogant and say, look, here's what we do well, here's what you do well. Is there a way we can work together that isn't, a win-lose thing? And by the way, please look at my whole enterprise, not just, what I do at Abington Home Health, but, maybe there's something, we've done that. We've looked at that with some nursing home, places like Welltower. They like to do buy to leases, But then, okay, well then I'd like to be your health system for all your nursing homes. That's not what they came to us about. But, that might be the difference between my wanting to do a deal or not wanting to do a deal. So I think creativity is really the key, is probably what I'd say.
Yeah, I think that's right. And when you look at the co-opetition model, I think that works, right? Not everything is a zero-sum game. In fact, very rarely is there a zero-sum game. So co-opetition does work in this case. So we'll close it out. And you've been very generous with your extra 8 minutes or so. With Neil's question, you've been very candid. So Neil looks like he wants you to be candid. What other health systems do you think get it? And he specifically said, name names.
I will name names. I'll give you one point of pride. For us, and then I'll name some names. So I think what's different about us, because there are some places that actually even do better than we do, but they tend not to be traditional academic medical centers. So I'm in this club with the top 25 academic medical centers, and I'm in this club that they have with 20 of the coolest IT places. And the funny thing is, I'm probably by traditional academic parameters at the bottom of that top 25, and I might be even at the bottom of coolness of those 20. But there's nobody in A that would even get in the door of B, and most of the ones that are in B are not academic medical centers. So look, there are places like Intermountain Healthcare, there are places like Providence, out in the West Coast. There are, obviously, Cleveland Clinic does some pretty amazing things when it comes to innovation. I think, on the academic side, I'm very impressed with what a guy named Niyam Gandhi does at Mount Sinai in New York. There's some amazing places when you look internationally, like Gemelli Hospital in Italy, or Sheba Medical Center in Israel, or Bangalore University in India. So I mean, look, I think there are places that are willing to do that. What I would suggest, because I get asked a lot, well, that's great because those are all pretty big places. But I think what can start to happen is, I think you can start to, the nice thing about innovation is you can join consortiums. So like what we're finding is, I just talked to you about Tendo and the partnership. I had a smaller hospital say, gosh, we have X millions of dollars to spend on innovation. Wouldn't it make sense for me to become part of Tendo? And what that would do is give you another hospital to work with. And I'd probably get a better return working with you and GC than my just trying to. So I think there are ways of getting involved in blocks. Remember, with innovation, you don't have to be next door to that place. Mm-hmm. We could work on the digital innovation and consumer experience stuff with a hospital in Texas. It'd be hard to do that in a pancreatic cancer trial, because we need to see the patient. So I think that's what I would suggest is. But look, Mark Harrison from Intermountain is somebody that I'm often on panels with. Rod Hochman from Providence. Believe it or not, I think the for-profit HCA has a really good. Right. Sam Hazen has invested a lot in innovation. And they're so large that they can do the pilot thing very well.
Yeah, that's fantastic. Well, we really appreciate your extra time here, and of course, the main closing keynote was just awesome. Everybody should grab the book, read it, and Stephen, hopefully you'll join us at a future Health Impact, and you enjoyed the format, and I hope everybody else did too. So we have a closing session that we are, Megan, if I'm not wrong, we're moving to the closing session, right? The closing session is not on this. Session ID, is that correct?
No, I like the hat. I think you wear it well. I'm going to get off. Thanks.
Thanks, Stephen. So for everybody else, let me just make sure we're staying here, because we want to bring everybody on to join in that closing part of our discussion here. So I believe we are staying right here. Okay. Great. Okay, great. Anybody want to join on here? Because as I do the closing in our normal Health Impacts, we kind of like talk to the audience about what you guys learned, what you liked, what you didn't like. Anybody willing to join me on stage here? No? All right. You guys must love the sound of my voice, because I'll just keep talking for hours. It's not a problem on my side. what I really enjoyed about today in the last couple of days was the candor. This one of the things we pride ourselves at Health Impact about is no BS, no PowerPoint, and the candor has just been great. And you saw that with Kevin yesterday. Kicking it off and with Steve here closing it out. And what we'd really like for you to do, especially in the audience, is go to these guys, ask them the questions, follow up with them because they do have a lot to share and they're willing to. Earlier today, you heard with Providence doing the same thing is they're not only sharing interactively if you ask them questions, but they're actually writing down what they are learning and sharing that with the community. So that's one of the big things that we're taking away from this particular last 2.5 days is people are willing to share and they're getting out there. Now, the other thing that we've talked a lot about is how do we know whether something is working or not? And here, what we're saying over the last couple of days is we see something's working, something's not working. That is all driven by evidence. And Neil, you mentioned evidence a couple of times in the chat with Steve, where physicians seem to be evidence-oriented, which is true in most cases. But a good physician friend of mine once said to me, physicians are still more eminence-driven, like it matters where you graduated from and who you are, rather than evidence-driven. But I do get your point that physicians are mostly evidence-driven. Administrators, very little being driven by strict evidence in the same way. So that desire for evidence, we hope that you'll join us in a couple of months. We have the Digital Medicine Conference. And if you don't mind, Megan, when you get a minute, you can add the link to the Digital Medicine Conference. So that conference is going to be focused purely on how do we get digital health to be measurable through objective, not just subjective means, and then figure out whether or not the evidence that is being emitted from the digital health that we're using is actually driving increase in quality, reduction in errors, lower costs, and other parts of the quadruple aim. So that conference is going to be December 11th through 13th, I believe, and Megan will, she just added the link www.node.health to pre-register there. So we hope you join us there. And the major items that are coming up over the next couple of months, you want to keep an eye on the CMS comment period, but which you heard the CMS folks talk about yesterday, is that the comment period ends on Monday. So it's not a whole lot of time, but if you have some comments about the telehealth reimbursement codes and how reimbursement is occurring, please do that. We know the patient access rule is kicking into effect early next year. We know the interoperability and data blocking rules are kicking into effect as well, even though there's been some enforcement action that has pushed that a little bit. So we're recommending you guys, stay in touch with these groups. One of the primary reasons for Health Impact is to make sure we get all the smart people together. Some of them will be on stage. Some of them are back at home doing real work at the same time. So we want to make sure that you're driving towards the networking part of this. And we've tried in the past to get networking to occur through these apps and other things. What we're seeing is people, they just get together in these kinds of conversations on the chat, and then they'll reach out. Like I've received a bunch of emails over the last few days. Hey, loved speaker XYZ. Could you get us in touch? Would like to ask speaker ABC a question. Could you connect us? So please do that as much as you can. Reach out. So Megan and Emily have been sending you guys emails. This is time to repay them by asking them about how to connect folks to us in these kinds of networks. And then lastly, what I'd like to talk a little bit about is, are there other formats? I mean, we're going to be in this COVID-ish environment for many months still, and we're doing more and more virtual. We'd love to hear from you about, is this format working? Are there ways of making it more helpful? Of course, all of this is being recorded. You're going to be able to rewatch it in case you missed any of the sessions that you wanted to see. But what we'd love to hear about is, how do we get our innovators in front of you so that you have candid views of what the solutions that are out there could be brought in front of you to evaluate better? So do you want virtual demos? The idea of virtual booths Some people like it. Other people are like, I don't know what this thing is, and I don't know how to connect with you. So tell us what would work for you, because you need solutions. You need new ideas. You need new thinking that the innovators have in droves. The innovators need access to you to talk to you about these and improve their products and move that along. And I think this model that we have, this opportunity that we have during COVID is to create new models. So if our innovation partners, the innovators, the solution providers could come to you with demonstrations or other things during our conference here or in between sessions or in between our events, like the next one is coming up in with Digital Medicine Conference, what could we do to help you make sure that you are getting the information you need from the innovators in addition to the speakers? And then how do you ask for more? The kind of interaction that you can do in a booth, for example, physically. Are we doing a good enough job in doing that virtually? Probably not, because we're all new to this. But what could we do is a really important one to look at. And your questions, on this audience, and especially in this one with Peter, with Steve Klasko, was great. We got a lot of interaction, a lot of questions, and you saw him being very engaged. So if there's some ways that we can improve that interaction, which we pride ourselves in, like we do, we assume everybody is smart in the audience. They're here to learn. Nobody actually knows what they're doing at this time. So we're going to all need each other to help each other. And that's what I'm thinking, that we got to figure out whether this model is working for you or you've got some ideas. So Eric mentioned that breakout sessions would be great. Neil is saying that legit case studies would be good, but need to be meaty. I like that idea a lot, Neil. I'm thinking the idea of having workshops. So think of it as I don't know if many of you have been to an unconference before, but this is what we do at our unconferences, where we have people in the audience tell us, hey, I'd like to see X and I'd like to see Y and I'd like to see Z at the beginning of the conference. During the conference, those who know those subjects will break out into rooms and we'll actually have working sessions. And so I'm thinking the idea of expanding a virtual booth or expanding these sponsored kinds of rooms might make sense to be more workshop oriented. I think if you agree with that, Neil, that might be what you're thinking about, these legit case studies that are meaty. John, I appreciate the kind words. Eric, on the breakout sessions, what's interesting is that it's unclear whether a breakout session needs to happen during this time frame, right? So do you all believe that these breakout sessions should happen at the same time, or do we focus on talks during our main here and then have a breakout session next Tuesday, right? Or next Wednesday or whatever. So because the model is different in this new world order that we are in, we don't actually have to do everything in this exact same time frame. So if you have some ideas about saying, you know what, during these talks, we want our innovators to come on stage, tell us what they do. Like, I really enjoyed the conversation we had yesterday with the Avail Technologies team that told us about their solution in a nice interactive way. Sada did that today. Yesterday, we had a bunch of communications from Google and others. So if that works, then we can spin out either during the Health Impact time or subsequent, or even before. Like, you can do things before or after the event, not just after only. So if you've got some thoughts there, we'd love to hear that as well. And Neil says he thinks that the breakouts need to be adjacent to keep people focused. And so, Neil, what do you mean by adjacent? Do you mean at the same time as the discussions taking place, or like parallel? So if you have some thoughts there, Neil, you can just put in if you thought parallel would make sense. So what we'd love to do is to see, there was a podcast that I just did last week about Health Impact, in which I talked about this as well. As we are all struggling with figuring out how do we make these as meaty as possible for you all. And if there's anything that you can share with us, do let us know. With that, I'd like to close us out with, of course, the biggest thank you to the Purpose Events team, which actually does all the work, and they are kind enough to let me sit here and talk to you and discuss these things with the speakers. But really, all this hard work is the Purpose Events team. You've got Megan, Emily, Andrea, and others that are back there doing all kinds of real work to make all of this happen. So when you get a minute, just send them a quick thank you note to let them know how much you guys appreciated it. And we'll make sure that they can continue that coming up in the future events. So join us at the Digital Medicine Conference. Please pre-register at node.health. And with that, I am signing off. Tip of the hat to all of you. And we will see you in a couple of months.